Insights from the world's best medical minds. You are watching TheRightDoctors.com.
Hi, I am Dr. Chaudhry. I am heading the Department of Pulmonary and Critical Care Medicine at PGI Rohtak. And last 3 months have been roller coaster for me. After I took over as the President of Indian Society of Critical Care Medicine, I came back. And from the first week of March, my story and my encounters with COVID started. First and foremost, we were not very sure what we are dealing with. And we realized that there is some illness which has happened in China, which is a respiratory illness, and is creating a mayhem. And gradually, we started realizing the gravity of the situation because of the pictures which were coming up from Wuhan, but also the alacrity with which WHO responded. Though people may have a difference of opinion, but nevertheless, it has been for the first time that it was very early, it's very quickly rather appointed and declared as a pandemic. So when I came back from the office, the first thing with the directive which I got from my government, because I'm a public servant officer, how we can respond this in our state. Obviously, Government of India was always there to guide us. And then we started realizing the issues. Suddenly we saw the first spurt when people, especially the students, and large number of them medical students who are doing their MBBS or undergraduation, they returned back. Fortunately, nothing happened, but it helped us in understanding and building up the things. And then the real problem started when we started having patients from the West. And the stories which were coming from Italy, one after another, and the number of deaths being bombarded into the bedrooms, into the drawing rooms, created an atmosphere of panic, which was already there, and it was further augmented and accelerated. And then obviously reports started coming from London. In the North India, and obviously the first case which we saw in the south of the country in Kerala, they handled it well. And we went in with our colleagues there, and the process of last 3 months have been really a roller coaster journey. To an extent that reading it from the front, obviously it was a privilege, but one was scared also. It required courage. Scare was there, no doubt about it, because of the things were the way they were being demonstrated, the way people were talking about it, and the way our colleagues in the medical fraternity responded to it. It was a new disease. Everybody realized that a monster has been unleashed. And once you get it, people initially thought that probably a death warrant has been declared. What one saw was when we admitted patients in it and we separated them and we isolated them, it was a new experience for a large number of us. We did do it, especially in patients of swine flu. A very small portion of SARS-1 epidemic had come up. But gradually we started getting the information, the numbers started increasing. And as I said, in the first wave which our country faced, especially the India, only cases were reported in Kerala, and it helped them then further redefining their strategies, and we at our state learned a lot from it. Why I'm talking to you is because this is a story which all of you have gone through. I have seen people going into panic attacks where the patients have been put into the labor room, suddenly reported as having your COVID, and the doctors, nurses running here and there. This is the sort of stuff which we have seen it to an extent that sometimes it has been created a lot of difficult situation to the administrators as well as the patients. We could see it, the running away of attendants, leaving the patients outside the hospital and moving away. What we realized that we have created from this monster, a social monster, where we started realizing that the people were scared to touch them, the medical fraternity. They were scared they may get it and probably they may not get out of it. They were worried about their life. They are worried about their families. Similarly, in the patient, in the field, in the social circle, anybody who had a COVID or was suspected to be COVID became untouchable to an extent that it has led to a lot of emotional trauma. Why I am saying is again is that one has seen the best and the worst. We have been, along with the public service officers, have been increasingly participating in the final disposal, respectful disposal of the bodies of the people who had died unsung because of corona. When I was dealing with it, I am also the one who got the infection, but I am fortunate enough that It was not a very severe disease. I recovered and I have joined back my duty after a period of 2 weeks. Why I'm sharing it? Because when you do the personal experiences, then you realize the challenges. First, I have realized the challenge of mine as a medical professional, as an administrator, as a policymaker. At the second place, I realize the challenges which a family of the coronavirus faces, what a patient faces, and how to handle it. It has made me stronger mentally, and it has also given me a reassurance and the to speak to my friends, all of you across, saying it. Let's get out of the panic which this disease has created. Let's move out of the fear which this disease has created, because out of 100, 80% will come out on their own. Additional 10% will need some support or more closer observation. And what is required in the last 10% of the cases? The only challenge is, do we have the capacities to deal with it? And during last 3 to 6 months, we have learned something extra. We've realized how it is spread. We have realized how you can how the pathophysiology of the disease is taking place, and what are the time periods when you need to act, you need to intervene. And you have also realized over these 3 to 6 months period is which patient needs your close attention, so that you can prevent the disease from taking a more severe form, more severe type, so that we can decrease the morbidity and mortality which is associated with the disease. If you see it, the cartoon which I'm going to depict right now will let you know that there are two components of this disease. And if we see in this cartoon or in this particular set which we are showing you, it beautifully explains to you what is happening. What you see here is that two things are happening, and I'm trying to put it as equivalent to leptospirosis. Not that it follows the pattern of leptospirosis. What you are finding at the phase 1 is an infection. When infection is there, then obviously person starts, it's like any other coronavirus disease. Most of the time, the coronaviruses which have been there in the human have been causing most of the time upper respiratory infections. They will have a sore throat, they will have a running nose, they will have a nose stuffiness, or they may sometimes be associated with a little cough which may persist for longer period of time. Coronavirus, the SARS-CoV-2 virus which we say, causing disease in the human. So what is very important for us to remember is that in this group of patients, two patterns are there, as I said, in the leptospirosis. In the first phase is that we see that these patients are having viral infection, and gradually, because persons have not been exposed to it, body tries to understand what infection is, and as a result of that, once it processes those signals, it starts making antibodies. When good amount of antibodies are there, it starts clearing the infection on its own, and recovery takes place. However, sometimes of people, the infection, which the antibodies which have been produced, or the immune reflexes or immune response which the body has got, lead to significant organ failure. Why the organ failure takes place? Because of the collateral damage which is. And the most common organ where we are seeing commonly this thing being happening is actually the lungs. People started looking at what is the reason. We had seen it in the patients of H1N1 epidemic, that is the swine flu epidemic, where we were finding that certain people were having much more evidence of low respiratory tract involvement, severe pneumonias. But people after initial scare were not as scared as we saw in the patients who are having COVID disease. The reason has been, now we realize it, that there is a particular type of a receptor which is coming into now the new jargon or the new vocabulary of everybody. And that vocabulary is SARS, in this case in SARS-CoV-2, gets attached to what is called as angiotensin converting enzyme 2 receptor. We all knew that in the lungs, basically when you are having through the aldosterone axis, the angiotensin gets converted into angiotensin 2, gets converted into other substances, and later on through the SARS-CoV virus receptor 2, it gets into different 1 to 7 portions which we are doing in angiotensin 2, and they are vasodilators. The net result is that probably we had never given attention to serum angiotensin converting enzyme receptors, which are far more widespread. And when we start looking at it, they're there in the lower respiratory tracts, primarily in the alveoli, primarily in the blood vessels, and we are also seeing being present throughout the blood vessels. That is why we are seeing varied manifestation of this particular infection. Primarily involvement is the lung, because of which we are seeing today that because of lung involvement, what is happening? It leads to very severe inflammation at this point of time. And the question which people have talked about, that there is an increased incidence of thrombopathy, which is a little unusual or different in this particular condition than other respiratory infections. Now, the autopsy studies which you have seen from New Orleans, which you have seen from Italy, which have been circulated also much more in WhatsApp, is that WhatsApp groups, in particular the social media, I will say, is that they're trying to say it's a bacteria, it's a virus, it is creating more thrombosis. Everybody is now making up a story out of it, but if we put all the dots together, what you see is there is an intense inflammation. Now, when you see a lung or alveolus where the gas exchange takes place, all of you are well aware that there are going to be two components. One of them, in this case, is what you are seeing is that there is an alveolus. Alveolus has a, so the pneumocytes, type 1 and type 2 cells are there. They have a basement membrane. Then there is a basement membrane, and then there is an endothelium. So what you are finding is an extreme degree of inflammation which is there. That leads to leaking of these cells, and that filling of what you call as non-cardiogenic pulmonary edema or inflammatory pulmonary edema which takes place. And simultaneously, this provokes the intra-alveolar vessels, where you are seeing the pulmonary capillaries showing intense thrombosis because of local effect, though it has also sometimes been seen leading on to significant amount of thrombosis at other places. And that is why incidence of venous thromboembolic disease also have been found to be high. So in other words, three things are happening. There's an intense inflammation of alveolus. Secondly, alveolar endothelitis taking place. And third, because that region is occur. Why with the leptospira? In the first leptospira, it is a bacterial disease where the foreign body or the antigen is working. Later on, the immune responses comes up. So we are finding antibody production, and that is where the dangerous phase of COVID starts. And certain group of people get it, not everybody. And that is where the importance of, I have realized the importance of comorbidities. And the most important comorbidities which we are seeing actually is the diabetes, obesity, and hypertension, and obviously persons who are immunosuppressed. Particularly within obesity and diabetes, we are seeing a huge combination. But remember one thing, if you have a control of diabetes, it's unlikely to be creating as much an issue. When I spoke to my colleagues in Middle East, I spoke to my colleague in Europe, I talking to my colleagues in India, what we are seeing is to the onset of this disease, we are seeing that number of people who had a respiratory or some other infections, etc., coming to us with a higher incidence of ketoacidosis, with a higher incidence of well-controlled becoming uncontrolled. It was related to this or no, but this is an observation which needs substantiation. So as we started learning up, we realized a timetable is there, which the cartoon which has been shown to you is depicting. That means first you need to get infected. After you have got infected, then either your body will accept it or you will become neutralized to it, and then nothing will happen. Other is that it comes up, it throughout the body, the viremia takes place, and you become symptomatic. Therefore, when you start looking at the timeline of infections, which this beautifully, the next cartoon is depicting it. So first you get infected, then you become symptomatic, and after you become symptomatic, then the next phase comes up. That is, you start, either you will recover, or at this point of time, because of the antibodies and immune complex production, you will get a severe disease and you will have an early pulmonary phase, and then gradually either you will recover from it your own, or if body puts a very intense response to it, that is the inflammatory, pro-inflammatory response, then you can have what you call as a cytokine storm, or sometimes you can also call as a macrophage activation syndrome. And that is what is responsible, my dear friends, in addition to having respiratory problems, worsening of them, again a multi-organ dysfunction, where we are finding nearly 20% of these people have kidney injuries. They have a very intense cardiac involvement, which is formed in terms of fulminant myocarditis, and later on you can have other organ involvement, including thrombotic strokes. You can have a delirium in these cases. And another thing which we found out very commonly in this patient, though it earlier phase was a diarrhea, and then they looked at it because of the presence of angiotensin converting enzyme receptor 2 in that gut. Another thing we are now starting to realize is that these patients have an extreme, they also affect the pancreatic cells, that each of the structure cells, and probably that is the reason because of which we see higher number of these patients of a diabetes going uncontrolled, or probably more important, or the complications which I discussed with you. So if you are not able to take care of this hyperinflammatory syndrome, it is going to cause the death of an individual. So when you see the sequence of event, probably here we have seen it to you. If you in the cartoon which I'm going to discuss with you or show it to you on the next slide, will very clearly define, and the slide which is next to this, or the cartoon which is next to this, will very clearly depict to you. That means if you have an infection, nearly 70 to 80% will become symptomatic between 5th to 7th day. Now that is what will happen. So from here the clinical syndrome starts. Then people recover another 7, so that becomes the 12th day of your 10th to 12th day of infection. Then either you recover or you start getting a breathlessness. Now after the symptomatic phase. And then the person, obviously, as I discussed earlier, will develop either ARDS, MODS, cytokine storm, secondary to that. So that net result is of what? The arrow shows very clearly is immune dysregulation, macrophage activation, endothelitis, and thrombopathy, which I discussed earlier. What is important to realize is it's a biphasic disease. Therefore, the answer lies in managing these patients if you pick it early. And what we are practicing at my institution, as that what I've been trying to reinforce repeatedly in various groups as well as my institution, is pick them early. So what have we started looking at it? So what is happening? We are trying to pick up early. How you pick up the inflammation early? If person, instead of settling down of a fever or was febrile or was symptomatic, more symptomatic. That is point one. Second point, which is very important, is that you start looking at what are the signs of inflammation. If you remember from the undergraduate time, the signs of inflammation are, you will have rubor, you will have along with it pain, you will have it along with the swelling, etc. That is for a classical pattern. But in systemic circulation, what will you see? You will have fever. Sorry. You will have fever. You will have fast rate because of fever. And along with it, you will see in these cases, person may have a significant malaise, person may have a feeling of fatigue and tiredness because of the cytokines which are released, and interleukin-1 is commonest, and gradually body with these pro-inflammatory cytokines, and over a period of time when the immune system takes care of it, you will see that anti-inflammatory immune system starts acting, it starts making a balance with it, and it gets removed. So another thing because of which we have early. So what is important is you need clinically picking up the concept of inflammation. We talked about fever, we talked about tachypnea, we talked about tachycardia. Along with it, what was very important is how you detect breathlessness. Person will complain, and first thing will be breathlessness feeling after going to the bathroom or to going to the toilet, or whenever a little activity. This is where they start. Whatever the activity was not otherwise caused, will start causing you breathlessness. How you pick this disease early, and the day is a pulse. We are following the principles of interstitial diseases of the lungs, where the first time they will feel breathless while on exertion. So what we are asking is, you look at pulse oximeter. Now duration there is 97 to 98%. If you find an activity drop of 3 to 4%, please immediately report to your nearest hospital. That is why it is important to understand that those people who are on home isolation, and the trigger point is between 7th to 10th day of illness. That is important. You may prepone it to the 5th. So what is important from the perspective? To have hemogram in all these cases, look for the total cells, cytopenias are there or not, and particularly you look at lymphopenia. If your lymphocytes counts are less than 15, it's a red herring, and if it is less than 10, you are heading for a bigger trouble. So simple test is available. Second, you get a CRP done, which is available across the board. The CRP levels, if you see, are high, increased, high, and along with it, if you doubling within 48 hours, again is a warning sign. For the macrophage activation syndrome, which is a hyperferritinemic syndrome, so you will go and look for serum ferritin levels. And along with thrombopathy, you will see levels are sometimes difficult. You can get D-dimer values which lie, but that can have an issue in diagnosing in pregnant females. Their values you have to go by the pregnancy. And finally, along with it, obviously it is good practice if it is available to get a procalcitonin to rule out that you are not having any bacterial infection. And along with it, if you have the facility to get an interleukin-6, that's a good practice point. But if you do not have a facility for IL-6, doesn't make a difference. Your most important thing for you at any point of time is a lymphocyte count. A, B is your CRP, and C is your ferritin. And sometimes people even have used LDH to prognosticate these cases. This is how we look at it. Once we have gone through it, then obviously you are able to understand it. And another part which people have not been recommending, but we have started talking about it, and we are trying to change the algorithm at this point of time. Cough is a good predictor of getting a lung involvement. If somebody does not have a cough before 5th day and gets a cough after that, then it will be important for us to pick up the cough point at that point of time, lung involvement. Now, the lung involvement is the key, and that is going to decide, besides inflammation, how strongly you are active. Most of the guidelines are not talking about it. Chinese did it. Now the Western world did it. And at Rohtak, we have also started now practicing it and trying to promote it. Please do a CT scan if possible. If you are finding a lung sign at this point, along with the desaturation, you are nearly certain, and it's a classical pattern which you tend to see in these cases of bilateral peripheral involvement, ground glass opacities, and gradually a picture of ARDS starts coming up. Now the question comes in, which most of the time patient asks you, doctor, do I have a COVID? Obviously people know it today. When you have a community spread, there is a lot of debate about it, whether there is a community spread in Delhi or not, or there is a community spread in Mumbai or not. And what we are trying to say, they're in certain areas not. But from all practical purposes, from the public health perspective, this is a community spread. There can be a difference of opinion in administrators, but from the medical perspective, anybody who is coming to you with a travel history to a red hot zones, that means in this case, you're Mumbai, you're Delhi, you're Indore, which has covered it now, or if you're in Ahmedabad or any other city, please do think in terms of it. Therefore, the next question everybody asks, doctor, how am I going to diagnose it? And that has again become a bone of contention. It is very important because today there is an epidemic going on. It becomes very easy for us to say, well, this is COVID related. But it needs to be differentiated from your other viral pneumonia like influenza. When we looked at our data at Rohtak, till end of March, out of 580 samples which we tested for H1N1, 380 were positive. We also saw influenza viruses. We also saw other influenza B and C as well. But later on, from April onwards, influenza has disappeared, and what we practically are seeing, and also because decreased testing has gone because of work taken by COVID. So my dear friends, we need to know the epidemiology very well. So when we know it, that this epidemic is going on, you start looking for the diagnostic tests. When you start looking at the diagnostic tests, there is a lot of debate which is going on which test to go up. The gold standard continues to be RT-PCR, no doubt about it, and rest all tests are checked against it. RT-PCR is an excellent test. It's a good sensitivity and a good specificity, but we must remember, now there are different methodologies. You can have a two-tube testing, you can have a single-tube testing. Two-tube testing, first you look for whether person has got a screening test, you do it and find out, and that is usually done for E genes. So first you look for E antigen, envelope antigen, and then after that it is there, then you confirm with RDP, RDRP, or with an antigen, or sometimes structural genes also. So that is important. And you must remember, when you are looking at a molecular detection, which is the gold standard, and in this case, again, I'm saying RT-PCR, but we have got now certain very quick rapid tests. The problem with the RT-PCR is that it will take 8 to 12 hours. But the advantage of RT-PCR is that you can do a bulk testing. The other point of care test which comes in the molecular detection are TrueNet and CBNet. Now, both of them have been used, these machines, extensively in a National Tuberculosis Control Program, RNTCP, and what you are finding is these have been utilized by now being for making point of care testing. The point of care tests are which you can do at the patient's bedside. Because we at RT-PCR, like we are seeing a lot of patients before surgery, there are surgeons asking for it. A lot of people in the labor room asking for it. Sometimes dead bodies have come up where you need to differentiate it, though ICMR recommends it, but people ask it and it becomes difficult for us. So at that point of time, to cut short the time, now we can use today TrueNet and CBNet. TrueNet was earlier giving only screening tests, but now it has been now approved also from the now around about for last 3 weeks for your confirmatory testing also. CBNet again is an excellent test where everything is automated, and you must realize there is a fundamental difference in terms of the viral medias we are using. The viral media RT-PCR is the viral transport media, which is you take the samples and they go up, whereas in patients of TrueNet or CBNet, we are looking at primarily virus lysis media, so spread of infection is less and it is a closed system, and you get results within 1 to 2 hours. So whenever we are in a trouble, like say a patient has come to the casualty and so emergency surgery is required, so what we do, we go for either TrueNet or we go for CBNet. Similarly, if person is having a dead body, we have to do it, we are going for TrueNet examination. So whenever you have an emergency, you want an urgent result, please go for either CBNet, that is Gene Expert, or you go for TrueNet examination, whichever is available with you. On the other hand, otherwise, its standard thing is that we take samples, sampling technique is the same, that you take it from the nasopharynx, deep inside, and the best thing is that the stick which comes to you, comes with the VTM, is that you have to find out the distance between the nose and this. And that much depth it has to go if you have to take the proper nasopharyngeal samples. Another thing is that when people try to do it put into the mouth or the oral cavity, you need to touch one left fossa, right fossa, center fossa, so that you take the samples. Only then it will be a complete testing. Therefore, pre-analytical error quite often are happening. Some people are trying to take in the nasal sample from the medial turbinate, but it will be a good practice point if you take good nasopharyngeal samples, and if you combine with oral pharyngeal samples, the false negativity reduces from 30% to 10 to 15%. But it is very important. Technique is the key. Therefore, whenever you are taking samples, again, common mistake which we do is that if somebody is coming expo, you do it in day 1 or 2. It is a good practice point. If person is asymptomatic, please do on 5th or 7th day, because that is the time pre-symptomatic or asymptomatic phase will be picked up. And patients, 80 to 70, 90% patients will be symptomatic in 5 to 7 days. The incubation period we know is up to 14 days, and from rare instances come to later on. Now, that is the one part of a genetic detection or a molecular detection test. A lot of things have started talking about, like in dengue, when we started looking at it, we only had a certain test which was making us a diagnosis. That was immunoglobulin levels. And in the immunoglobulin levels, again, you have a large heavy molecule and a relatively lighter molecule. They are the M or the G proteins. When you see the cartoon which I showed you just now, here we had 3 things we talked about in the diagnostic test was about antigen, antibody, and molecular test. Molecular test also actually look at antigen. When you see this particular interesting cartoon, it will remind you of it what you see actually in dengue to make an impression, physical or a visual impression, that first of all it will be antigen which will come up, and is at that point of time you will see RT-PCRs will be effective. So most common, the timing of RT-PCR becomes important. So my suggestion to you is, as I said, 5th to 7th day, maximum will be positive in first week. As you go into second week, the positivity will go to less than 40% or so. Now, as far as these antibody testing is concerned, when you see the first antibody to appear is around 7th day, not more than 40 to 50% patients will be there. And gradually these antibodies start picking up, and then you see they peak around 14 to 15 day and then disappear. That is the IgM antibody. On the other hand, the IgG starts a little later, and by the 15th day, it starts going up, and by 28th day, majority of the people are going to be immunoglobulin. How robust is the response is going to decide the level of immunity, because there's a lot of debate about it, about the immunity certificates. I don't believe in it. What is very important is that we must follow the basic principles of virology, that if you have been infected, you have recovered from it, it is likely to give you certain amount of immunity. Now, it's an early days, how much level of immunity you can always do an academic discussion. But the net result is, because the way you do academic discussion, it goes to the bedside of the people and they are scared. Therefore, my suggestion to my viewers, in particular my colleagues on the medical profession, is please have a look at it. And the antibody detection test has gone into disrepute because we try to use it for a long period. When the lateral flows which came up, the rapid diagnostic test, has created a lot of hype. Media was also about it. Remember one thing, there is a limitation with everything. What strain you are using, from which country it is coming up, how they have been preserved, how they have been transported, everything becomes extremely important. Therefore, when you are looking at it, whenever you will find in rapid antibody testing, which you do, why we were saying rapid antibody, you could get answer in half an hour. You could do it with the blood or you could do it with the serum. But it has been an utter failure in our country that not more than, we looked at it, Rohtak, and we did it in around about 80 cases who were present on that day, and it turned out to be positive only in 12 cases. So the point I'm saying is, it's a sensitivity and specificity were extremely poor in our condition, and I've already discussed and talked to you with the reasons. So what is the advantage of antibody test? Antibody helps you in serosurveillance. It can tell you the silent infection. And I again narrate you a story of my very close family abroad, had symptoms, recovered. She's a doctor. And when the hospital checked it from the, when you start looking at from in terms of the from infection control department of the institute, she found to be antibody positive. That means she probably had a subclinical malignant infection. So they found her to be robust antibody response and can be put on duty without fear. So that's one good advantage of it. But if you're finding that was IgG, IgM will tell you to begin with, yes, person has antibodies, has developed infection, and if person is asymptomatic, good IgM response, that means it's a robust response and person is protected, which will gradually give over to immunoglobulin G. So if IgG is there, that means infection is at the remote. On the other hand, when IgM is there and IgG is not, it is a recent infection. And when you are looking at between IgM and IgG, that means it is intermediate. So this is how we realize from the antibody testing, we can actually date the infection at which point of time it has taken place. Now, there is another test which has come up, which ICMR has also approved, that is a rapid antigen detection test. It is a point of care test. Rapid antigen detection test is a point of care test. And that is what we need to see. There is a lot of, I saw a couple of articles, people are challenging it. But remember one thing, the advantage of rapid antigen test. Like if you see, again, I'm coming back to another viral story, that is the dengue. In this case, you will see what you do first. You do non-structural NS, non-specific antigen first. That picks up first beside the RT-PCR. Then you look for IgM and then you look for IgG. Similarly, in this viral infection, when the virus will be there, that is the antigen will be there, that should be picked up. It is a rapid test. It is a point of care test. So on the bedside, you can do this particular test. But ICMR wants to know the data. Therefore, they have said who wants to do RT-PCR, they must use the app and upload to ICMR. I think that we need to follow the line of the law and the guidance of Government of India and Ministry of Health in these matters. So once you have done the testing outside has been reported up to 80%, but the tests which have been tested in Indian condition by the ICMR and All India Institute of Medical Sciences, it is around about 60%, 40 to 60% depending upon it. But nevertheless, if I can detect 40% of the patient, let's say the minimal positivity of it, which has been documented in a limited number of samples, only when we start practicing it, we will come to know, my dear friends. Therefore, at least it reduces the burden of RT-PCR. So if you have 40 people positive on antigen testing, take them as COVID, and there's no confusion about it. It has a good specificity. That means if it is negative, then probably the true negatives it can pick up. But it is important for us that if I'm testing 100 cases, very strong history which fits with the case definition of ICMR, the Government of India, which has been come up, you need to test rest of them with RT-PCR. What we are planning and what we have suggested is strategy, and I'm extremely happy that ICMR has also started the same. First, we do antigen testing. If person has to go for emergency surgery or to the labor room, or for, let's say, even some other things where emergent action is required, at that point of time, you can go for a point of care RT-PCRs, that is either gene export or TrueNet, which is available with you. And if then they are not able to find an answer, probably then you go for RT-PCR. Or alternatively, if you do not have point of care TrueNet or gene expert after antigen testing, then you take a sample and then you go for what you call for RT-PCR testing. I think this is how you do it. So practically the load on the lab will reduce, A, the turnover time for the diagnosis will reduce, 2, if not for 100%, at least for nearly out of 140 cases. Once you have done the antibody testing, as I said, if you're suspecting strongly a patient and it is nearly 5th to 7th day, probably a role today is of high resolution CT scans of the chest to pick them up. And that's what I have tried to explain next. When you look at that CT scanning testing, in those cases of CT chest, when you start looking at it, what you find? You will find ground glass opacities, which will be there. And again, they will be peripheral, they will not be central. And they will start coming up from the basis. And then you gradually see a consolidation can be there, or a book-like picture will be there. And you can also have a significant picture like ARDS. It has an excellent negative predictive value for telling you that there is no active chest involvement in terms of lung involvement. But what is important is you need to, if you have a strong suspicion, there's a strong history, case definition, you need to look for RT-PCR. What we are following, depending upon the availability of the testing, is that we go for RT-PCR, and if there is a doubt about other infections, which ideally should be looked for influenza, para-influenza, because with the summer season coming up and now the monsoon coming up, you will see a lot of deluge of monsoon fevers like scrub typhus. You will have an association, again, influenza coming back. So it is very important for us at that point of time to do and not forget other things. And CT cannot differentiate. So you may have to do at that point of time the point of care testing for your COVID or RT-PCR for COVID or for other diseases. So that limitation, we must do it. People have come up with CT test scoring system to pick up, but important is it needs to be done between 5th to 10th day, preferably around 7th day, and more so if there is a recurrence of a fever, mild cough, or any doubt of breathlessness or desaturation. Once we have done that, obviously, let's summarize it, and then we see how we are going to take care of these patients. When you start looking at the incubation period, obviously, it will not require any treatment. But when you start looking at the patients who have a symptomatic period, now symptomatic period, I said, and I'm repetitive, is the first phase of symptomatic period is going to be your A, is where the disease will be minimal, or what we call and defined as a type A disease, or minimal symptoms, no symptoms. And if there is no symptoms, fair enough, it is asymptomatic. And when you see symptoms, then you call it as pre-symptomatic, and then person becomes symptomatic. Usually lasts for 5 to 7 days, then majority will recover from there. At this point of time, majority do not actually need more than paracetamol or sometimes non-specific things like vitamin C or zinc. But what is important is, as per our guideline, hydroxychloroquine is being used here and nothing more. People have tried to use ivermectin and doxycycline. Whether it makes any difference, we don't know. Hydroxychloroquine is recommended. There's a huge debate about it. A lot of data is coming against it, but we continue to use HCQ. But please do not use azithromycin if you do not have any evidence of it. Now, even ICMR has removed azithromycin out of it. So please, if you have to use HCQ as of today. Another drug people are talking today is a favipiravir. I have no experience, but the data is still early. Whether it will make difference or not, I don't know. But what is important for us to remember from the studies which have come up where it has been claimed, the problem in the challenge is that in most of the patients, nearly 80% will respond on their own. The only claim is that probably it reduces RT-PCR levels faster. Again, that is important from the public health perspective. But I will not go beyond that, because the number of tablet size which you eat and the toxicity and teratogenicity, it practically makes irrelevant for us. But yes, if somebody has got 2 or more morbidities like obesity, diabetes, obesity, hypertension, probably you can offer it to your patients. Then obviously it comes up along with it. The next phase is an early respiratory phase or a pulmonary phase. That is where with the HCQ you can add steroids Now HCQ has also by and large has been taken away by the ICMR for the Indian guidelines. We are not using in moderate severe cases. This is the time when you can actually use antivirals. And that is the time where quite a few people are talking in terms of use of either remdesivir or repurposal use of lopinavir/ritonavir with ribavirin. People have discouraged or discarded lopinavir/ritonavir in favor of remdesivir and all. Data is still out, jury is still out. But if you have to use it in combination with ribavirin, whether you see the data coming up from Hong Kong or even from the Western world or other places where they've used a combination, it is no worse. In fact, the study which was published in Lancet from Hong Kong has shown that ritonavir, lopinavir with ribavirin and their variable use of interferon in that case has led to a quick recovery. And if you see the MERS-CoV data also, they've used combination of ribavirin with your lopinavir/ritonavir, and it has been found that probably the people for post-exposure prophylaxis as well as who were treated, they responded well. So what is important is to look at the side effects, because people tend to, we have used a lot of now lopinavir/ritonavir. We have an experience in both HIV as well as now in influenza, in COVID also. So ribavirin people are not using, but you need to use it. When you want to use ribavirin, please remove. As you see to it, you check in J6PD. As far as the hyperinflammatory syndrome is concerned, that is the one which is the most dangerous one. And that is where you are going to use steroids. Now the question is, suddenly you will see there is a spurt and craze for Decadron. Decadron is a good drug, and we have used 6 to 8 milligrams, which have been used in the recovery trial, and people are saying it is good. There is a lot of debate, but once the inflammatory phase starts, so initiated by virus antigen, started with an antibody, and you are finding a state where these immune complexes are creating mayhem, where you are finding antigens, and that antigens are in the lungs, they are in the blood vessels, they are in the kidneys, and on every organ system. No wonder multi-organ syndrome is there. So if you find a rapid spurt which you detect by CRP, which you detect by hyperferritin, which you detect by increased IL-6 D dimer levels, all are pointing towards hyperinflammatory state. So these are the places you will use corticoid. There could be differences in terms of use of steroid duration between category B with the early respiratory phase or late respiratory phase, but it is very important, my dear friends, to realize when you want to use them, please use it for adequate point of time. A large number of these patients are diabetics. You look at it, their sugar comes under control, and you may have to use insulin simultaneously. We have used both methylprednisolone and dexamethasone. Use any steroid you want to use. But what is the key is that use that steroid which is available, but in equivocal doses. We are using methylprednisolone 0.5 to 1 milligram. If I go by our national protocol, it is saying 1 to 2 milligram of methylprednisolone per kilogram body weight. Or you look at equal amount of Decadron, which will be 0.2 to 0.4 mg per kg of dexamethasone. That is what you can use. If you can use hydrocortisone, if there is nothing available, you can use, but in equivalent amount of dose. That is the key. Quite often what we are finding is majority of the patients will respond again along with it. To use or not to use antiviral, again, is in the domain. In the severe hyperinflammatory phases, antivirals will not make that much of a difference. What will make difference is the anti-inflammatory therapy. That's what we are going to discuss now. Steroid is again a part of anti-inflammatory therapy. And that is what people started using a compassionate use of when you start looking at it in these patients. Compassionate use of, in these cases, of tocilizumab, which is IL-6 inhibitor. It first was used for the CAR T cell therapy. And we are finding it is like a immune reconstitution. So you are finding large surge of pro-inflammatory cytokines coming up. IL-6 is a prototype. And if you find the levels there high, but some places people have used even more than double the CRP or doubling of other things. You use it suddenly, if repeatedly with which is coming up, what we have seen, we are now using it for last month or so, we find a rapid resolution of these things which have taken place. But the data, if you see the next slide, you will see we are talking about a lot of anacarna, which is IL-1 antagonist, IL-6 antagonist. People are also talking about JAK inhibitors. Point is they're trying how well we can take care of cytokine. So what my take on this is, what our experience is, that we need to reduce the antigen load and at the same time we need to look at the target organ damage which is being caused by these cytokines. So what we are using is an antiviral A to reduce the antigenemia, and secondly, at the same time, we are trying to use immune modulator. The first immune modulator for us to be used is the steroids. If things are not working with the steroid and progression grows after 24 to 48 hours, in the moderate case, what we are doing and trying to use is actually now the convalescent plasma, which was used by the Indian Council of Medical Research. Now it has been put as a part of compassionate use. Now that is entirely a different topic, but that is one place where we are trying to use convalescent plasma and has a role to play. Now, when you start looking at a cytokine storm, which is happening in these patients, what is that you give up to 6 to 8 milligram, but not more than 600 milligram at one point of time. If your patient doesn't respond or responds and rebounds, then again you can use for the one more time a use of interleukin-6 is allowed. I think that should be very clear. So if you have to treat in asymptomatic patient, best policy is wait and watch. You want to give something, it is HCQ. Alternatively, if persons have comorbidity, you can use favipiravir after informed consent. That is the only place which is there. And then if person comes with a moderate disease or a hyper, or you start an early lung involvement, you start adding steroids. And along with it, if the person doesn't respond and march goes on, that is the time for convalescent plasma. And people are now exploring the use of tocilizumab at this point of time. And if person gets a severe disease, you need to have a steroids first, antivirals, and along with it, you will use in these patients tocilizumab. And obviously, some people have also tried to use cytokine filters, removals, etc., along with convalescent therapy. But now we are realizing the best advantage of convalescent plasma is in phase B in the intermediate or moderate disease. I think important. Antiviral, which one will you choose? The buzzword today is remdesivir. I think still jury is out. Nowhere it has shown to reduce mortality because most of the time it was used later on. Same was true for ritonavir, lopinavir. The NIGM trial which was published, the antivirals were used on 13th day of illness when already disease have gone advanced. Did you find any advantage of using oseltamivir when the ARDS has set in? Therefore, the role of antivirals will be to use them early in the course of disease rather than late in the course of disease. Remdesivir is one promising drug. Still, how much effective it is, and there are a few more which are coming up, including, I will not like to take because they are an experimental drug. And obviously, if you do not have the availability of remdesivir, please do not hesitate to use combination of lopinavir with ribavirin. Now, once that is there, the most important significant portion where all the planners have been putting your emphasis how to manage hypoxemia. When you start looking at managing hypoxemia, Gattinoni, etc., came with the two different types of phenotypes in it, the L and the H, which simply say high compliance, low compliance. That means low elastance is a high compliance, high elastance is a low compliance. So that was the early time, and they said probably easy to ventilate, easy to do it. And the word which was coined for it was, my dear friends, all of you know, is a hypoxemia. Person is working, person is a febrile, feel little fatigue and doesn't know whether he or she is having a breathlessness. That is where the importance of pulse oximetry is there to pick them early so that you intervene early, act early to reduce mortality and morbidity. Once hypoxia occurs, then obviously the delivery system of oxygen becomes important. You start from nasal prong, you go to non-rebreathing mask or Venturi mask, and then you go for high-flow nasal cannulas. Initially, HFNC, that is high flow nasal cannula oxygenation therapy, which is a high flow therapy, and NIV came in lot of disrepute because of probability of high spread of infection. Now we have got good PPE, good other things. I think they have become now the mainstay. From early ventilation, we are going to late ventilation. But I think a judicious use of these equipments is required because more we delay it after a certain point of time of intubations, patients may die early. But nevertheless, one of the very important component when you're treating with hypoxemia is the amount of flow which you're using and FiO2 which is there. So gradually you step it up, and what we are finding, and we are trying to convert it from the ventilators to a setting in the high flow, or what you called is awake proning. Because what is happening in this is that when person is on ventilator, you prone them, their oxygenation improves. Now here what we are doing is entirely different. Here person is awake and they are asked to prone. But they are not asked simply to prone. First, the person, let's say, is lying supine, they are asked to sit, then they go for a lateral rotation on the left side, then they may prone, and then the right rotation and left. And what is the best suited for the patient, we go by that. And we are doing it routinely, and we leave it to the choice to the patient in which he or she feels comfortable. And quite often there you will see them playing with their smartphones when they are prone lying down. So I think it is an important, it has come of age, and quite often you need time for the lungs to heal. If you give them adequate time, they recover quickly. But if continuous march is there, then you may have to use along with CPAP or NIV, and the best interface for them is going to be your helmet or full face mask. Whether to choose CPAP or whether to use BiPAP or NIV, I go by PCO2 levels. If my PCO2 levels are normal or increasing, I will prefer a BiPAP. If they are low, I will prefer a CPAP. But C2, if they start going elevated, avoid crash intubation at any point of time. And once you have intubated these patients, follow ARDS net trial protocol of low ventilation. What is very important in this cacophony of lung, we forget the heart. Heart is important, and myocarditis which occurs in these patients can be a lot of trouble. Therefore, please look at it. Any person with arrhythmia, any person with unexplained tachycardias or bradycardias, please go for troponin I or CPK or even BNP if your kidney is fine. If you find any of these things elevated, please be careful about it. Pulmonary embolism is not the only thing which is affecting the heart. Myocarditis is as important. Similarly, we are seeing in these patients high incidence of coronaries. They resemble coronaries in the younger people, they found normal coronaries. Therefore, it's a challenge. It's a chimeric model which we are trying to see all the time. It keeps on changing the shapes, but you must remember. Similarly, there is another condition you need to look at it, whether you are having just an incidental COVID and underlying condition. Why I am saying so? Recently, my daughter also had it. And when evaluated, she was having vomiting. We evaluated, she turning out to be having associated hepatitis C. When we saw it later on, it turned out that probably what we saw, it was an asymptomatic incidental corona. Therefore, please don't blame everything to corona. Look for the other diseases which may be responsible. And finally, along with it, my dear friends, we've already talked about it. I think we will look at the algorithm where what we are trying to follow at my institution, and that will be after that. That gives you an idea if a patient of COVID comes, how you will evaluate. In this case, as I said, patients will be into two groups. When you detect them, either they are symptomatic or they are asymptomatic. If person is asymptomatic or minimally symptomatic, that means there is no breathlessness. That is very important. There is no tachycardia, there is no significant breathlessness. What you need to do is you follow it up. You, on the 5th day of all these cases, we are trying now to do lymphocyte count or TLC, DLC, that you can simply remember that. Look at lymphocytic counts, as I explained, what is the level, grade them into less than 20 is lymphopenia, less than 50, 15 to 20 is mild, 15 to 10 is moderate, and less than 10 is severe. People are talking neutrophilic lymphocytic ratio, you can take that also, but if you don't do that, simple, this will help you out. One. Second, you do CRP levels. Third, if you have availability of ferritin, get it done. If you have an availability of any other D-dimer, you get it done. It is a good practice point if you can do it. And what is important is, most important is heart rate, pulse rate, obviously the one thing, and SpO2 and respiratory rate. Anything which is abnormal, 10% of the baseline, please look at it. Fever should start settling down. And then again, redo it on the 7th day. If any cough, any breathless shortness, that good practice point if person can have, and you have an availability to have a CT chest. And then shift over if symptomatic to the second chain of algorithm. Here what we are doing is, a person who is symptomatic, we keep a very close watch, and we are admitting these patients with two comorbidities. People, some say one comorbidity. If it is well controlled, we wait and see. Especially if you are in a home isolation, be careful. And here in this cases, once they have two comorbidities, or they are symptomatic or having breathlessness, please put them in high dependency unit. We cannot follow the Western model that you send them home. You have to keep them under observation of some doctor, if not in your hospital, but with the colleagues. I will suggest that you please make a group of families which respond to one person, and they have connectivity to the hospital. So referral chain is maintained. And then you see and assess, and if you find that CRP is high, your tachycardia is high, then you obviously start using immune modulation, and the first drug of choice is steroids. We usually try to use in 5th to 7th day onwards. Less than that, you can sometimes find delayed resolution of viremia, or you may cause more viremia. You use steroids, give it adequate time of 24 to 48 hours at least, doesn't respond, and still it is responding to a comfortable oxygen therapy, go for convalescent plasma. And if you find there's a fluctuation are very rapid, that is the time to use tocilizumab in these cases. Clinical fluctuation, clinical rapid deterioration, there neither steroids will work, neither convalescent plasma will work. That is the time to use tocilizumab, because that will act quickly and rest of the things can be added up later on, padded up. So steroids, convalescent plasma, if deterioration, then you may use tocilizumab. And obviously, along with it, you will use oxygenation therapy. And once you will follow these things, I'm certain that probably you will be able to manage these cases. There is another group of a patient which is a relative slow indolent phase. They're far more difficult to react. First cases with rapid courses are dramatic. They are the responsibles for causing sudden cardiac death. But the later one are more recalcitrant, more resistant to treatment, and therefore you need to be more. Another thing which we have started with the follow-up seeing is you discharge these cases, they come back with a recurrence or a fever. Be careful about it. A lot of inflammation is going on, and that is what you have to be careful, not only in pediatric but adult patient. What is called as a post-COVID, post-inflammatory syndrome. So there, depending upon it, the severity, if it's a low-grade fever, you may try indomethacin, but if it is a significant lesion which has come, you may have to use steroid for 2 to 4 hours. You may have to do a repeat CT scan at that point of time to see the resolution and organ damage. So my friends, I've given you a whole gamut. It's a long talk I have delivered to you, but what is important is it is your clinical acumen with support from a good lab network. And what we are finding in the problem in the chain of management is discontinuous care. People are scared. You have a poor pre-emergency care. We are not giving clear instructions on home isolation. What are the red flags needs to pick up? Then you have to have a good pre-emergency services, seamless coming to the emergency and admission into the COVID units and COVID wards. So it is a learning curve which we had it to begin with, and with the last 3 weeks, once we started learning, right now we have more than 20 patients in intensive care units with us. We have refined it, but remember one thing, do not forget to treat comorbidities. Diabetes is a pain in the neck in these cases. We looked at our death data and we found that nearly 2/3 of the patients have comorbidities. But remember this, in India, because of a younger population, we are seeing younger people. Majority of the people are in their 40s and 50s. Elderly, I am seeing little less. And we are seeing it much more in the area where you have seen the swine flu has created. And I asked one of my colleagues, my assistant professor, Professor Dr. Manjunath, I said, what we are seeing is that in Delhi, whosoever is going is getting I'm giving just an anecdote, not that that all cancer patients which are there having some of the other problem related to COVID. Why the reason is that at my institution, I'm out of the problem. Came the reply. So they're coming from rural background and they're coming from the urban background. And if you see it today, this pattern is stark, is clear, that we are dominantly seeing the relentless march of this disease in the cities. And in the rural areas, we are not seeing it. And that gives the government the confidence to say that, yes, probably there is no community spread, but we have to be very careful. Anybody who is coming from these hotspots, if we'll go to the rural area, may take the disease together. Therefore, it is important, my dear friends, as not only you have to treat it, but at the same time, as a public health person, you have to ensure that isolation, quarantine, and management of these patients is done properly and as per the expectations of the public as well as the people. And trust me, if you do it, you pick them early, as I have been saying everywhere, pick early, hit hard, keep on hitting till they stabilize. And the keep on hitting, hit hard is your steroids, hit hard is your tocilizumab, if need be, your conventional plasma. Keep on hitting with them is a continuous use of steroids. And also when you hit early is antiviral. So it's a combination of these three things. When you will do, I am certain we can reduce the mortality and morbidity of this disease, and we can give a model to the Western world from the India. Yes, we have picked up, we have realized, we have decoded it, and we can do it. But please, one thing as a patient which I have faced, I request you to do two more things. Don't panic yourself. You are safe, but pick it early. Don't try to hide it under the carpet. If you most of the time I've seen doctors avoiding it. Who will run my ICU? Who will run my... No, please see to if you are safe, rest is safe. That is very important. And along with it, what is very important is be a public health man, and please request people who have recovered from COVID to come forward and donate plasma. With these words, I think I will say, and to conclude, that it is a disease where 80 to 90% people will recover on their own. And my request is stop looking at the figures of the death. Please look at it. Out of 190 people are getting all right on their own or with your minimal intervention. Where your intervention is required on 10, be a messenger of hope, be a messenger of faith in the trust in the public, and tell them we are there to look after you as a healthcare worker. But at the same time, please look at your own health, because if you are careful, you will move into it with the confidence. Probably you will save yourself and save the patient. And remember General Sam Manakshaw, who said when we went to the war, doesn't mean that we were not scared or we were not afraid. We were. But it is a job for which we have been trained. And it's bloody very well we do the job. I'm using and quoting the word of Sam Manakshaw. Thank you very much.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.